In other industries, as people rise through ranks of an organization, they often have expertise from the front line. And that's not the same as in healthcare. And it's not to say that every hospital leader needs to be a physician, not at all. What it is to say is that there's a lack of understanding, a lack of dialogue, a lack of common language. So what winds up happening is physicians and nurses feel like they're commodities. They're not believing that the people who run the companies and the hospital systems can hear their concerns or address their concerns or alleviate their burdens through technology. And so when you're working hard and you're afraid to say you feel like you're working too hard because that's not the culture, and you feel like you're being turned into a commodity, it's kind of a perfect storm for how to create burnout.
Well, thank you all for joining us today on a topic that is sort of near and dear to me, our team at Wobot, and really across the industry. There has been a lot of conversations about mental health. 65% of therapists have no capacity to see new patients. Globally, we're seeing this massive supply and demand imbalance for mental health support, and what it means for people, right? It means long wait lists, 48-day national average in the US. But lost in those stats is the impact of mental health care to the healthcare workforce itself. A recent AMC report said that 79% of providers have said that worker shortages affected them and their place of work and their mental well-being. It's a crisis, in fact, that has elevated itself in a recent Surgeon General workforce burnout advisory. In fact, there's this poignant point that's made in the advisory that starts with, our health depends on the well-being of our healthcare workforce. So I thought, let's break down this problem. And I have two amazing leaders in this space to help us do that in today in our episode of Meeting of the Minds. So let me introduce them. I'm going to start with Janae Sharp. Janae joins us from North Carolina. She's the founder of the Sharp Index, which is a nonprofit dedicated to reducing physician suicide and burnout. Mother of 4 kids, a physician suicide loss survivor, who in our previous conversation has helped us understand that if our healers are not healthy, our health system will fail. And I think Janae brings a very interesting perspective with a background in healthcare IT and patient engagement to help health systems really quantify and fix organizational problems that lead to physician burnout. So with that, Janae, thank you for coming today as one of our guests. Maybe we could start with telling us a little bit about the Sharp Index.
Oh, thank you. I'm really glad to be here. The Sharp Index is a nonprofit we just sort of started in 2018, dedicated to improving physician mental health. And really, sometimes I can't believe that I even started a nonprofit. We were working with healthcare IT. I was writing about healthcare IT, getting really into interoperability, and John died by suicide. That's my former husband. We have 3 children. He did not finish his residency. And what I found was, in healthcare, there's a lot of shame. I think everywhere, actually. There's a lot of shame about mental health. Like, people don't want to talk about it, and people have a really hard time with it. But some of that wasn't there in conversations that I was able to have with healthcare leaders, because I'd already lost John. But also, more than that, I was kind of upset with healthcare, that the response to my kids losing their dad doesn't look the same as the response to someone losing their dad to, like, a car accident or cancer. And what it told me was that we don't actually believe in mental health, or we don't understand it, And so I decided to start where I was. There are a lot of reasons that this happens, and there are also a lot of reasons that we aren't making it better. And there are a lot of opportunities for improvement. And Sharp Index is involved in getting scholarships for people involved, getting mentorship and support for students to help healthcare physicians look more like the populations that they're serving. And also we did direct childcare grants during the pandemic and now, and we were able to do a lot with, the data science, the cool data science people that I knew, to kind of look at creating an environment where technology is an asset rather than something that people don't necessarily love. So I say we started it before it was super popular. And that was true. Like when we started, people didn't necessarily want to join a remote group. They didn't want mental health support. Physicians were like, I'm good, and fast forward 4 years later, and the demand for support is monumental. Like our demand and our inquiries about getting support went up, over 300%.
Wow.
Almost immediately. So once that shame and stigma was gone, people really were ready to get support.
Wonderful. Well, thank you, Janae, again for joining us. And I think to your point, I'm so happy to also bring a physician host as well. So joining us is also Dr. Kristan Staudenmayer, who joins us from Northern California. Kristan's triple boarded in general surgery, surgical critical care, and clinical informatics. I love the fact that both of you have that technical side of this, by the way. An associate professor of surgery at Stanford, been at Stanford for, I think, since 2008. Expertise in trauma, emergency general surgery, and critical care. I know, Kristan, you've also researched areas around trauma systems of care and serving vulnerable populations, the elderly and the like. And I know you've also been heavily involved on the advocacy side to improve care and outcomes for patients with traumatic injuries. So really excited to have both of you on today. Maybe, Kristan, you can share a little bit as sort of kicking off the session. Why is this issue important to you personally?
Yeah, well, I want to say first, thank you, Sheetal, for inviting me. I think this is a really important discussion. And I think that we need to have dialogues such as this much more often, to the point that Janae made earlier, which is, I think we're still trying to make this an okay topic to discuss. And so thank you so much for inviting me. Yeah, I actually see this problem on many different levels. I wear a lot of different hats in the healthcare system, as you pointed out. And from each of those different positions, I see the relevance of this topic. Starting off big and broad, we've got a big workforce issue in this country. And I think a lot of it is being driven by burnout and lack of satisfaction. And certainly you can't take care of sick patients unless you have a healthy workforce, but you need a healthy workforce in numbers. So we've got a small workforce that's not doing so well. And it's not going to be able to meet the demands going forward for the next 10 to 20 years with where we're at right now. So as I work on improving healthcare systems, that's a significant barrier to being able to accomplish important change. So that's at the high level, systems level. But, from the physician perspective, I can speak very personally to it. On the front lines, in general, there's a sense of being overworked and undervalued. People feel burned out. If they express it, people are feeling more comfortable expressing it, although there's still a stigma with admitting you're feeling burned out, but people are expressing it more and more as it's become okay for people to say, I'm not doing okay. But when people do, I also note that you can see it triggers everyone else's same feelings, and it opens the doors to the discussion more. And so but it also affects the care that gets delivered. It is challenging when you're trying to deliver care and you're working with people who are not fully checked in. So it's a practice challenge as well. And to be honest and be completely transparent, there are times I feel burnt out where I ask myself, I'm like, why am I doing this? This is just crazy. This is too much. And so I see it from all those different perspectives. And it's an important problem. It's going to impair the health of our country. And it's also created an entire class of new patients, which are the providers.
Yeah, in many ways, I can see why the Surgeon General started with our health depends on the well-being of our healthcare workforce. So maybe to frame up the conversation, we start with the basic, like, what is burnout? The advisory goes to define it as, and I have it here, burnout is an occupational syndrome characterized by a high degree of emotional exhaustion, depersonalization, for example, cynicism, and a low sense of personal accomplishments at work. So maybe Janae, I'll start with you. How do you define it?
I mean, your likelihood to quit in some ways. We've done some work about burnout, differentiating burnout and depression, like in surveys, and burnout really is, a disconnect from your job. Maslow defines it and says, it's a syndrome involving emotional exhaustion, depersonalization, like no accomplishment. It's like when you're a robot, sort of. I think of it as the disconnect between the job you want to do and the job you're hired to do and your ability to do it. And in healthcare, we also talk a lot about moral injury, like because they're healers, they're trying to help people and save lives, literally. It isn't just that you can't do your job, it's that you're not being given the tools to save people's lives. And so when I'm talking about burnout, I try to think of it's nuanced. It's both you might quit and also you might lose all your faith in humanity because as a physician, you can't save the patients that you have the skills to save.
Yeah, that's great. Kristan, as a physician and one that's also supported the training of new physicians coming into this workforce, like, does that reflect of sort of what you're seeing on the ground? Anything else you'd add to the sort of that definition?
Yeah, I think that the definition is it's a good, concise decision that covers a lot of the important facets. So I agree with that definition that you shared, and the way I see it, kind of building out what Janae was saying, is it's burnout are those feelings or those lack of feelings that come. I think you measure it by people quitting. I think that's the metric that tells you, that's one of the metrics that tells you that it's happening. And I do, speaking to your point about trainees, you see it in trainees as well. They're entering the system, they're younger, they have a lot of energy, which I can appreciate now as I've gotten along in years, which gives them a little bit more of natural resilience. But at the same time, they're feeling it. And there's a whole nother webinar on how we train physicians, which I think really sets up for burnout down the road, because it puts a lot on the backs of residents. Sure. And I think uses up some of that energy in their youth. The good thing I'll say is that I think people become more aware of that. And I think life is slowly getting better for residents. I don't think fast enough, but I think it's getting better for residents than what happens after they graduate.
It's not like burnout just appeared in the last couple of years. It's not like this advisory went and was sort of aha moment. It's been happening for a while. Why are we at this spot now? What was the buildup? It's
been there. I've actually known 4 physicians who have committed suicide. And it was clear the organizations, the societies, they didn't know what to do with it, nor how to prevent the next one. But it's been growing for a while. And I think what really has prompted a change was COVID. I think COVID was a pause button on many of our normal daily operations that forced people to reflect and created a need to say, hey, the world might not be what we think it is anymore. And then people reevaluated where they were in life and what they were doing. Since at Stanford, for example, since COVID, our nurses went on strike. Our residents voted to unionize, and that's happening around the country. And we have a large number of early retirements. And people were tired, hit COVID, took a step back and said, what am I doing? And a lot of people decided that they didn't like what they were doing, or they didn't like how they were being managed. And so they spoke out. So I think COVID was a trigger that unleashed a lot of what had been building over, I think, decades.
It almost feels like we haven't even quantified the problem that's going to happen in the next decade as you start seeing that workforce sort of go through the early retirement. That's I think that's an area that probably hasn't even been measured. In terms of the measurement today, like the cost of burnout, maybe Janae, can you maybe give us a sort of a sense, a scope of the problem? I know that you help healthcare organizations quantify.
Yeah, I think it's actually hard for normal people to understand, because they estimate the cost between like 125 and 190 billion dollars with the healthcare shortage, and just spending related to burnout. And that's based on Harvard Business Review. So for each person, that might be $3,400 to $10,000. That's not super relatable. Hospitals are shutting down. People are finally quitting. I see it as like a great turning point. You can put pressure on individuals in the system for so long until they decide they're going to walk out. And the cost of that is the cost of creating a system that meets the needs of patients and of physicians, and either the healthcare organizations we've set up will pivot or they'll fail. So that's, it's what is it, 20% of our economy? So that's the basic cost. It's no big deal, just like 20% of everything.
20% of the U.S. GDP is healthcare. That is not small. That's for sure. Kristan, maybe you could cover some of the sort of the structural or systematic issues that we're seeing. Like, how do we get here?
For one, since the beginning of time, I think physicians haven't put any cap on the amount of work that we do. It's when you're very mission focused and you're thinking about patients, it's easy to not check yourself about when you might be working too much. And so I think culturally, what got built in was this sense of work more. It's always about the patient first, which philosophically has a lot of strengths. Patient first is a principle that every doctor agrees with, but I think we've also not checked that or balanced that with what's the consequence of not taking care of yourself. So that's been part of the culture for a long time. And then I think we, as medicine has progressed in the last few decades, what's happened is it's added a layer to that, and that has made it a little bit more challenging. So currently, I believe 70% of US physicians are employed by hospital systems or by companies. And as physicians have become employees, they have much less autonomy. So it's one thing if you are working 89 hours a week and you are your own boss. It's a little bit different when you have somebody saying, hey, you need to work 80 to 90 hours a week.
I guess the other side, Janae, is on the having you working with health systems and the executives there, is the impact on the patient side. Is there anything you'd probably add on the patient side from that perspective? Like, what are they feeling? What are they seeing?
I'm not familiar with all of the patient safety statistics, but I do know that over 1 million patients per day would lose a physician to suicide. And
wow,
that while we've had all of these staffing issues, they've seen a huge rise in errors and in bad outcomes that are related to inability to provide the care. I think it's like a 19% increase in what's going on. Also, to the point of how we created this, I think it is somewhat the system. So just, billionaire overlords using the serfs to, create a larger empire, and it's not quite working well in an educated society of people who can communicate. Like, people don't like it anymore. Like, on a large level, there's push and pull between power structures and human rights. And also, we aren't very good at dealing with death. We aren't very good at dealing with that. And a lot of societies say that's part of our ability to live a full life, is understanding of death. Or even religions always look at that question, and without being grounded within the framework of understanding and being comfortable with that, being able to talk about that, being okay with the human condition, it was not going to be a system of healing. And I think that's across the board. People, not everyone is good at dealing with that, and that's normal, and that's also okay. But it's something we can work on together.
Yeah, and I'm really, as we sort of enter the last sort of third of this webinar, I'm really curious from both of you, like, how are organizations responding? Like, what are we actually seeing being done? Because I think we've covered what the issue is, why we're here, the cost associated with it, both human, but then also the impact on the economy and the health of this country. How are organizations responding? I'm not sure if, Kristan, you want to take this first, or Janae, you want to take it, but I'm curious, like, what are you seeing?
Organizations recognize it's a problem to some degree. I don't think they really have the full depth of scope. And I only say this because when I have discussions with healthcare system leadership, sometimes there's still a discovery process there. So I think even though there are data and there are numbers, it's still not fully appreciated. And the focus tends to be, and this is coming out of medical specialty organizations, it's coming out of institutions, it really is focused on building resiliency. And fails to acknowledge those structural features, which are directly under the control of health system leaders, that can really have an impact. And as a result, there's a cognitive dissonance that arises. So when a person has been hired to sit in your clinic and sit next to you, and this does not happen at Stanford, but a friend of mine had this happen to him, where he had a person assigned by administration to sit in his clinic with him and to keep reminding him to move along so he could see all of his patients, and would knock on the door as 15 minutes was approaching to make sure that he could fit in as many patients as possible per day. So when you have somebody who's at your heels, nagging you to move faster and faster to see more and more patients, and then you hear from your leadership, we'll give you tools to make you more resilient, there's a cognitive dissonance. I don't feel resilient because I feel like I'm being overworked and I feel like you're micromanaging. And this is an example, I think, of how there's a lack of full understanding of what's actually happening. That's just one example. So I think, overall lack of full understanding, and two, a lack of appropriate recognition of the drivers leading to inappropriate responses.
When we look at people who have lost faith in their leadership, a recent Deloitte survey came out and said that fewer than half of people trust the organization's leadership to do what's right for patients, and even fewer, 23%, trust the leadership to do what's right for workers. And I think that's important to know. Whatever we're doing, it's not like the best. Programs that are succeeding are usually ones that involve physicians and ones that involve them in the decision-making process. I would tell leaders, it doesn't really matter what you pick as long as the people who are doing it are the ones who picked it. Those will have better outcomes across the board. And that's something that is harder, takes more work. And in some ways, you see people having those conversations, the same people having the conversations, the talking heads have like entered the chat, and I love them, but sometimes they're talking heads, and they talk a good game, but you have to look at the data. You have to look at the fact that people aren't trusting their leadership, and the systems that are working are the ones that are taking it from an approach of, you know, our employees are our life. Like, these are the people that allow us to be here. It is important. I don't know if it's important, but one thing we noticed was physicians that were slightly burned out, they were slightly unhappy. They didn't necessarily want to be involved in like a well-being program. They didn't want to be like, you know, they didn't want to do like a super huge feelings thing. So they would be more involved if it was like a mentorship program or something with leadership. Other things that have really worked are taking a moment in like at the bedside, like in the midst of care, like taking a moment to recognize humanity. So my 2 cents.
I just have to echo what Janae is saying. I agree with everything entirely. In fact, when you said participate in a well-being program, I kind of swooned a little bit. I thought, oh, I have to add that to my to-do list. That I have to hunt down the well-being program, figure out what it is I need to do, and then I have to do more things. I don't have time for that. Like, I already didn't have time to begin with. And then the piece about humanity, I think, also matters. And I personally have discovered that. And maybe this just happened as I've matured as a physician, or this is in response to just all the pain everybody has felt to the COVID epidemic. But I spend, I don't know, maybe 10% more time than I previously did with my patients, just talking to them about them. And I find that returns some of that, any sort of sense of loss that you feel with being part of, you know, feeling like you're a cog, gets recovered, and the patients appreciate it, and you appreciate it.
Yeah, I'm just looking at some of the comments in here. Dyke mentions wellness is something you do with your people, not to them.
That is so true.
That's brilliant.
I mean, sometimes I say it's a myth. Like, I'm like, okay, self-care. Oh, right. Like, just another thing on your to-do list.
Right. Janae, what are some other ways that organizations are quantifying the problem? Like, how do you, because I think sometimes we need, you can feel the energy in an organization, but that the moment you quantify, it becomes more important. What are, like, this tactically, like on the ground, what are some of the quantifiable, except that first way you answered it, which is people quitting, but what other variables are you seeing?
Sometimes when we talk about the cost of healthcare worker burnout, we're like, oh, it's billions. But like, we aren't really good at this math. We aren't super good at measuring it either. That's like, everyone talks about, like, we don't necessarily need measurements, sure. But what we need is measurement that actually matters. People who are looking at this and hearing it's a problem, like, do they have a standardized measure that is absolutely going to show you the value of the program? No, that doesn't exist. Like, will they be able to justify their investment in people? Well, you know, like, how good are you at math? And the answer in healthcare is like, not very good, because we're basing a problem that should last many, many years, even a lifetime, on the math of 1 year of bills and balance sheets. So we quantify it through different measures. You can look at, there are custom metrics tools. There are lots of different ways to measure this. And all of them say it's not that good. We haven't found the magic metric that would be able to show you that investing in humanity is a good decision. We're not very good at that math. And I will say it might be because mathematics and a balance sheet isn't usually why people do the right thing. It isn't usually the motivator for behavior. So I was obsessed with this, by the way, like right after. I was like, if people understood that you were losing $1 million every time a physician left, they just would actually care about people. Maybe they would help people get to school, but like, it isn't the math that's the reason that people actually take care of each other. So that's like an answer, but also a non-answer, because part of it's like, these metrics we're using, the money metrics that actually matter, they do not work for this.
Interesting.
And
Yeah. Go ahead,
I would
Kristan.
say that metrics that are currently being used in the form of, say, wellness surveys, they generate a sense that things aren't right, but they don't generate, the questions aren't such that it helps organizations to know what to do about it. And I think that when you're trying to develop metrics, those metrics should be directly usable for those purposes.
And are we seeing that organizations are responding in innovative ways to change policy? Or, Kristan, you had the story about hitting a certain, say, patient visit census for the day. Like, are we starting to see any light, any organizations that are sort of a beacon?
I think there are some organizations that have done better than others, but what I'd say is what's moving first is not coming from leadership. It's coming from grassroots. So as I mentioned, it's coming from organized labor. And for example, with our residents recently unionizing, others around the country are doing the same. The intent there is to actually change the power imbalance and to have a greater say in what that experience is. And it's the same thing on the nursing side. Most nurses are seeing about a 20% raise across the country, but they're seeing it not because it's being gifted to them. They're seeing it because they're organized and they're demanding it. So, again, I think healthcare has historically been very reactive, not proactive. And if you look at the landscape coming at us, I just saw some statistics where the average hospital median margin has not bounced back after COVID and is currently sitting around negative 3.5%. And over 56% of hospitals have negative margins. And by now you would have expected that we would have recovered, but the truth is that staffing costs have been driven up because people now realize,
right,
particularly nurses, what their value is. Because you had nurses who were working alongside our traveler nurses who were getting paid 3 to 4 times what they were getting paid. And suddenly they said, hey, if that's what you're willing to pay for this job, why am I working for so little? So right. I think hospitals going forward to survive, I think as Janae was saying earlier, are going to have to be a lot more strategic about how they approach their workforce. They're going to have to, right now, they don't have a relationship with their workforce. They're going to need a relationship and they're going to need trust and they're going to need to invest in that. But I don't think they are there yet as a whole.
Yeah, I agree with that. Like it's something that they're going to need. They need trust. Like when we look at that, the people who trust their leaders, they're going to be the ones who succeed, and those programs are better. I wanted to say to your question too, one of the things that the nonprofit Sharp Index does is every year we have awards. People are nominating leaders, programs, and individuals that have done great work in mental health, and we've had sponsors from all over, just like recognizing that. And some of those stories have been amazing to hear. Last year, after the pandemic, we had to create a new category for, people who are invented a nonprofit, who started a new organization to meet this problem. We hear about the Lorna Breen Foundation was a winner, and they used their, they took what they had, which was knowledge of the healthcare landscape, and created policy change. And now healthcare organizations are working to say, you know what, let's take away mental health questions in licensure exams, which, are probably, maybe, I'm not an attorney, a violation of Disabilities Act. Like, they're looking at it from a different perspective. And I will say that it's a whole new category. This is something new. There are new organizations that are making change, that are helping. And being able to hear those stories, by the way, if anyone listening or in the call knows a great thing, like nominate them. It's really helpful, because in the day-to-day, it can be hard to find hope. And there are people who are dedicated to doing great work.
That's great. And then I think Lisa shared a link right there in the chat. So please nominate. It's right
Thanks,
there.
Lisa.
Yeah,
tell me good news. We all need good stories. I need better stories.
Well, I think to Kristan's point, right? It's for instance, when the residents got together and started working together, it is raising awareness, right? And you get to a critical mass. You mentioned a name that I'm hoping everyone recognized on the call. You mentioned Dr. Lorna Breen. I was at a symposia, and I was speaking about the provider workforce crisis, the spot we're in, and I just I kicked it off with, how many people know Dr. Lorna Breen? And there were like 3 out of maybe 100 people that sort of raised their hands at that point. Janae, could you share a little bit about Dr. Lorna Breen and what we saw come out of Congress?
Yeah, actually, I just spoke with someone who was working with her in the emergency department.
Wow.
She was a physician. I don't represent them. I think they're great, by the way. It's like a great organization. She was an emergency medicine director in New York and died by suicide. And her family started the Lorna Breen Healthcare Heroes and introduced an act, the Lorna Breen Healthcare Provider Protection Act. And I remember some of the stories of people saying, people told her to get help, but she just said, you just can't. And not everybody realizes what it's like, and not everybody sees that. But they're an organization who has been able to work with policy and partnered now with the Schwartz Foundation and other groups to improve the delivery of care. And yeah.
I know that
I don't know them personally. Like, I do know them, but yeah. I think it's great. It's also hard because I kind of love the idea. People talk a lot like where there's a margin, there's a mission, and in mental health there isn't always a margin. People don't always want to pay for it, so they're like, okay, we'll just make a margin. They said, they went to our lawmakers and said, look, we need this. This is something that people need, and recognized that was true. People do need it.
Right.
So created some of those, some of the ability to do that.
We have a few questions that have come in to our Q&A panel here. So I want to throw a couple out just related to maybe this one right here. And maybe Kristan, you could take this one. It's from an anonymous individual who says, for many of us, we are reluctant to ask for support because there are few mental health care providers that are exquisitely trained in supporting physicians, APPs, nurses, and other healthcare providers. Many don't understand the moral injury or the impact of delivering bad news to a patient, i.e. you have cancer. Wondering if you have any real world thoughts or ideas that teams and organizations could incorporate every day to support providers.
Yeah, I really appreciate whoever submitted this question, because I think this is really important, and it's something I think everybody is so aware of, but it never gets discussed or addressed. And when I put my ICU hat on, I'm having these discussions a lot. And it's taken me a couple of decades, I think, to get to a place where I'm able to have those discussions. And I think I probably manage it okay on the back end too, but there are some situations where it's pretty challenging to manage. So to ask your question about what organizations can do, we get as physicians little to no training on how to have conversations about difficult things, and we get absolutely zero training on how to manage your feelings after you have that conversation. So I've gotten to a place where my personal approach is one where I think, well, if I'm talking to somebody about death or illness or serious injury, They have to know everything that's in my head, and I can give that to them, and they deserve to have that. And sometimes that's going to involve death, sometimes it's going to involve bad things. And I found that they're already thinking that, so they appreciate having it surfaced rather than saying my doctor is holding back and not telling me the truth. And I found that actually makes me feel better that I've given them what they've needed. I've had to arrive at that on my own. And palliative care, the profession, is developing these sort of frameworks to have these discussions, and they've really advanced the field. But for the most part, most people are on their own trying to figure this out. And it is not to be underestimated, the impact of that moral injury. I can't tell you how long it takes me to recover. If I have taken care of a child who has passed away, and I do that with my trauma head on. Sometimes if there's a child who's been hit by a car, and I have to tell the parents, as a parent myself, that is one of the hardest things they can do. I actually schedule downtime. If I've had an experience like that, I cancel my meetings the next day if I can, because it's so heavy. But most people don't. They plow on. They might bury it. They might find they're avoiding other things. And we really need to create structures and processes that help not just educate, but support that front end work of talking with families, and then the back end work of how do you manage it afterwards for yourself personally.
Janae, would you like to add anything?
Yeah, a few of the organizations that are out there, it looks like someone also commented that they are working with that. I've talked to therapy aides and like debriefing the front lines, organizations that are putting together training for mental health professionals who are working with physicians. There are a few experts that you could do that project with them, put together the CME. I don't know where they are at in that process, but having specific training so people have a better understanding of that is part of what's going to improve things.
Well, I know that we're running on time here, so I'm gonna maybe ask one last question, and I know we like to end our conversation around meeting the minds with sort of, if you had the power to do one thing to improve the mental health well-being, and in this case, frontline providers. I'll start with you, Janae. What would it be? And then we'll go to Kristan.
I could do any one thing. That's too complicated, because you could just say, just fix it. Remember that Saturday Night Live thing where the guy just gets on there and yells, fix it? That's totally what I would do. Just fix it. I think right now what I would do is create the opportunity for more physicians to get great education and plan forward, so that we have fewer disparities in health outcomes. So we have more physicians who look like the populations they're part of. So I would increase access to education. Like, we see huge shortages. That's something that we're working on now. Just imagine someone who had kids and, a female surgeon who can have kids in residency and not give up their family. Creating a system where that's possible is what I would fix right now.
Perfect. Kristan, to you?
No pressure.
Yeah, I mean, if you consider the big buckets of structural change, which address drivers for burnout, so at least some of the drivers for burnout, versus a bucket where you say support, training, mental health support for providers. You consider just those two big buckets. I would say start with eliminating some of the drivers first, because those are immediately, I think most immediately within the realm of control. And I think that what that involves is characterizing the provider experience, workload, and identifying what's needed to make it possible for providers to deliver the best care possible. Give them the space to be able to do that. And what that requires is, at the very top level, this financial balance sheet versus nebulous. There has to be a dedication to saying that's not what you're going to prioritize. You're going to prioritize stabilizing your workforce, and you're going to look at the cost of the workforce instead of saying what's the cost of having, more nurses or having more redundancy in the system. You're going to have to actually approach it very differently, and that has to come from the top. So I would say start with the structural issues, start at the top, and really be sure that you're doing the math in a way that makes sense.
Wonderful. Well, thank you for the guests that joined us. Kristan, Janae, thank you for all the work that you do in serving our communities and serving sort of the healthcare organizations.
What would you do? What would you fix?
Oh, you're good, Janae. You turned it on me.
I'm like, wait, we can't close before you answer.
I would, as a partner to a provider, I would say a lot of organizations need to, and kind of echoes a little bit of what both of you said, but I think there's an investment that's required that's not a wellness kit. I think there's an investment that's required that is maybe different for everyone, depending on where you are sort of in your life. And I think organizations need to be receptive to like giving local management teams the control to do what's right for their team members, right? And we see that in a lot of different industries. I'm not sure if we see it inside of healthcare because we run sometimes a system that's run on spreadsheets, as we see in some of the comments here. But that's probably what I would do, Janae, is I'd probably move some of the control back to the ground. I know that we're seeing employers move or physicians move to the employed physician space, but let's not forget why they got into the medicine. So that's where I would probably sort of push to. And I think we'll end the webinar with one point that was in this Dr. Vivek Murthy's advisory, which is our health depends on the well-being of our health workforce. And then it says, let's take care of those who are always there to take care of us. So thank you all for joining. Kristan, Janae, ever grateful. Thank you.